Thanks to all of you for your commitment, month after month, year after year, second Monday of the month. Thank you so much to all of our supporters, especially Sierra Health Foundation, who has hosted us here without a blink. We just had the most wonderful meeting with Chet Hewitt, the president of the foundation, about some larger community level work that we're going to be doing. And I will just say, it's wonderful the way so many of our RightCare leaders have grown into national leaders. So for instance, our first chairman of our San Diego University Best Practices, Dr. Jerry Penso, who at that time was with Sharpery Sealy and was our first leadership award winner. He then went to be, he's now the CEO of the American Medical Group Association in Washington, D.C., taking it to the national level. Next example is Betsy Thompson, our former co-chair here of this group, of our Sacramento group. She left Region 9 HHS to now be the head of cardiovascular disease for the Centers for Disease Control. And she's doing a couple of pretty cool things for RightCare right now. One is, I asked her if she could join us on the second Monday of the month in November here, and the answer is yes. And we're going to turn that into a much bigger day, which, as of this morning, we realized we're going to have with us the head of the Blue Zones project, which is an international project on scientifically assessing these 5 communities around the world where people live longer and healthier than elsewhere, including there are 5 of these designated blue zones that have been highlighted on the covers of National Geographic, and the research about them have been funded by the NIH, by the AARP, and they're working with Harvard School of Public Health to be very analytical about what are the overarching similarities between these communities. And increasingly, the researchers are starting to work with communities around the United States to see how can we apply these learnings into cities that need to adopt a healthier culture. So they have expressed an interest in us, Sacramento, woohoo! Through our co-chair who had to leave, Dr. Joe Skye, the Air Force guy, who happens to have been raised in one of the blue zones. There's only one in North America, and that's in Loma Linda, California. And he happened to grow up there. He went to medical school there, and he's one of the speakers, in addition to his work at the Air Force and for RightCare. He speaks for Blue Zones. So after we had the incredible opportunity to host the U.S. Surgeon General here in a private meeting about 5 weeks ago, a lot of things have percolated from that. Turns out the U.S. Surgeon General is very high on the Blue Zones, and we had expressed a concern about Sacramento being a hot spot for heart attacks and strokes and diabetes. So now the feds are very interested in thinking differently and more broadly about what can be done to turn that around. So that conversation is just starting to really percolate, but a wonderful thing that came out of our meeting with the U.S. Surgeon General is they're going to have a meeting at CDC 1 month from today where several of our leaders, including myself, have been invited to a 2-day technical meeting on trying to create an action plan for getting 80% of hypertensive patients to goal for blood pressure by 2022. So a lot of really exciting, cool things happening. Welcome. Make yourself at home. It's okay. We want people to come. So 48 people have signed up for this meeting. And as usual, right at noon, several of them haven't quite gotten parked and situated. So next month, on Monday the 9th, Dr. Matt Wanacott, raise your hand, has volunteered.
I'll hold the fort down. I'll be here with you.
He's going to chair a very exciting meeting where we have phenomenal speakers coming in from Kaiser, one of whom is the head of Kaiser Clinics Research, Dr. Steve Sidney, who's going to be talking about a study he has been the principal investigator of since 1985 that shows the impact of early detection of coronary artery disease. And it's really mind-blowing work, which we had presented at our Stanford group about a month ago. He is going to be paired with the exercise physiology guru for Southern California, Kaiser. And I'm really sorry that I won't be here for the meeting, because the reason I had invited those two together was because there's some misinformation in the world about, yes, exercise is very, very good for you. You should be doing 30 minutes of exercise every day, day in, day out. Do it. But for people who are at very high risk of heart attack and stroke, that's got to be a more nuanced and careful equation. Those are not people you want to be out on a 100-mile race from Tahoe to Auburn. So we now have the power, like Jacqueline Weiss was talking about, to do a much more precision medicine approach. So we need to do the multi-level approach to get towards zero heart attacks and strokes. We have the knowledge, whether it's from the cultural aspect that we learn about through the blue zones, healthy diet, natural exercise every day, lowering the stress level, getting that 8 hours of sleep, and, you know, having a glass of red wine at 5 o'clock. That's from the blue zones. I'm not making it up. It's part of the formula. So we want to go the full spectrum, from the healthy behaviors and the healthy communities that enable those healthy behaviors to the precision medicine that we now have to stop almost all heart attacks and strokes and cases of diabetes if we would just apply it. So we're on a really good path. We have amazing leaders around the state and increasingly connections nationally and even internationally with excitement about this work. And I am so grateful for our physician leaders who make this possible, and for our best practices organizations like Greater Newport Physicians that even though they're in the IPA model, they think outside the box, they reorganize how they deliver care to the point where they are at the 95th percentile for blood sugar control for the diabetics through using a team-based care model. So thank you, Andrea DeCoro and team. I've known Andrea DeCoro since I think we met in 2009 at a major meeting in Southern California where we brought the deans of schools of pharmacy together with health plan medical directors to talk about, by adding a pharmacist to the care team, you get that blood pressure under control, blood sugar, lipids, much more effectively than if the doctors are really working on their own. So to unburden the physicians, the team approach is worth working through, and we're going to learn about that from Dr. Coyne, Dr. DeCoro, and team today? How did they operationalize it? Because it's one thing to see it in the RightCare packet. It's been on our website for 10 years. The data is there. How do you operationalize it? That is tricky, difficult, hard work. So we have some really hard workers here. And I apologize that Joe Sky had to go back to the Air Force Base. There's a big computer thing happening, and he's an artificial intelligence kind of guru. So I'm going to leave it to Dr. Bill Baumer to introduce our speakers, but before we do that, I think we want to go around the room and introduce ourselves to one another. Just say your name and your organization, because we don't want to take too much time doing this. But one of the things that makes RightCare work is that people know each other, they trust each other, and they come together month after month to work the equation together toward getting towards zero. Now we do have some new faces in the room, so it'd be great for esprit de corps building to go around the room. Could we start a microphone over there with Jessica Nunez de Ibarra from the California Department of Public Health? And thank you, Jessica, for your support for our work.
Good afternoon, everyone. Jessica Nunez de Ibarra, Chief of the Chronic Disease Control Branch for the California Department of Public Health. Very happy to be here, and I'm going to pass the microphone, but I do want the group to know that in this new administration, new governor, new agency secretary, the state of California is in a really great position to do more about healthy aging. There's a master plan for aging that the governor has asked be created by October 2020. We also have a new task force on Alzheimer's statewide that will involve many of our staff. And I share that with you in terms of some of my priorities, but that I have pledged with Hattie and many of you, as we've been working and waiting for this point in time, to prioritize blood pressure above all things that we do, controlling blood pressure. We feel there's just so much that works when we do it together. So I just wanted to share that with you, know what my agenda is: blood pressure, blood pressure, blood pressure. But it's an exciting time, and so thank you again for coming. Again, this means the world to us at the state when there's just so few of us trying to do it. And that being said, I also wanted to introduce you to two new team members, Chiyoko and Wen, and they're going to speak to their roles in a moment, but please introduce yourselves to these program leads. I often cannot come to these meetings, and you'll see me less this coming year, but I wanted to let you know who staff are, and we do prioritize this meeting. Thank you.
My name is Darren Toddy. I am a program supervisor and a pharmacist for Ambulatory Care at Sutter Health.
Darren Giverson, Director of the Ambulatory Care Management Program in Sutter Health.
Don Hufford, Chief Medical Officer of Western Health Advantage.
Hello, I'm Chiyoko Grievous, and I am the Diabetes Prevention Lead for the Prevention Forward.
Hi, my name is Wen Xinfan. I work with Chiyoko on the Prevention Forward team doing the diabetes management. And thank you for this time to choose us.
Hi, my name is Andrea Quiquio. I'm the director for the Greater Sacramento Division for Dignity Health, so 6 hospitals. Happy to be here, just moved from Michigan. So just arrived here from Michigan.
I couldn't hear what organization you're with.
Dignity Health.
Wonderful, welcome. Thank you.
Hi, I'm Joan Werblin. I'm a retired nurse, and I am the current chair of the California Chronic Care Coalition.
Good afternoon, Yvonne Rodriguez, Sacramento County Public Health.
Dave Herbert, the CEO of Sutter Independent Physicians.
Kristen Robinson. Kristen Robinson, I'm the Chief of Chronic Conditions Management at Kaiser Permanente.
Susan Ivey, I'm a family physician and professor at UC Berkeley School of Public Health.
I'm
Jessica. I'm a nurse case manager at UC Davis.
I could not hear that at all.
I'm Jessica. I'm a nurse case manager with UC Davis Health.
Welcome.
I'm Annie. I'm also a nurse case manager at UC Davis.
Hi, I'm Rosemary. I am a pharmacist from UC Davis Health Management and Educational Online.
Hi, I'm Jada Garutia. I'm a clinical pharmacist with North Bay Healthcare, and we're looking to start pharmacy out now in care setting, so hence why I'm here.
Nancy England, Clinical Pharmacy Program Manager at Blue Shield.
Andy Hope, Regional Director of Quality and Systems Improvement for American Heart Association and American Stroke Association.
Mark Aikman, Dignity Health Pharmacy Ambulatory Care Service Line Supervisor.
Jacqueline Weiss, I'm with Genentech. I'm the Regional General Manager.
Annie Higashi, Regional Account Executive for Barrier Incline Pharmaceuticals.
Hi, I'm Trish Boharkas, Clinical Program Manager in Quality Improvement with Blue Shield.
I'm Tony Colley-Perry. I'm a community person. We sponsor a diabetes conference every year. This year will be in February. And on the 24th of August, we'll have a conference on advancing African Americans in the field of nursing.
Hi, Neil Kalatsu. I'm going to be joining, I'm a physician by background. I'm going to be joining UC Davis Health Institute for Population Health Improvement as a health strategist this month.
Hi, I'm Justin Kalika, pharmacist in CDE. I have a role position as a medical science liaison for Novo Nordisk and diabetes, obesity, and cardiometabolic disease company. Glad to be here.
Thank you very much for those introductions to everyone. Having mentioned that people were leaving the program here and going to other areas, I want to impress you, this is not a sinking ship that people are leaving. But realize that the people leaving here, we do not allow them to achieve what's called escape velocity, where they can escape the gravity of Earth, meaning what goes up, these individuals has to come back to Sacramento. So we are delighted that these people do return to Sacramento. They return in new roles with added responsibility. Betsy Thompson will be back here this fall. The Surgeon General will be back here. All of these people actually come back with added velocity and responsibility to enhance the program that we have in Sacramento. And today we spent the time looking at ways of further expanding the Sacramento program beyond what we focused on, and perhaps medical care and treatment protocols and prevention, to actually going to one step further and perhaps what we would term social determinants of health, and bringing up that shore as well. All of those efforts are a team approach to try to improve healthcare in the Sacramento region. Now, we're delighted today to have three speakers up from Southern California who are going to define what you will see as a very successful program. The first, the team is Brian Coyne, who is a board-certified family physician in family practice and the physician champion for team-based care within Greater Newport Independent Practice Association. In addition, Andrea DeCoro is here, and she is a longtime RightCare champion. Although she's very young, she is a longtime RightCare champion. She is the Vice President of the Clinical Pharmacy Services and Performance Improvement for MemorialCare Medical Foundation. Her role involves development and oversight of pharmacy, ambulatory care pharmacy, performance improvement, and risk adjustment for both MemorialCare Group, and Greater Newport Physicians. The third speaker on the team that will be presenting their data is Dr. Kristi March, who is the manager for Clinical Pharmacy Ambulatory Care Services, again for MemorialCare Medical, the IPA division, as well as the foundation. So we're delighted to welcome these individuals today to present a very successful and possible situation that we could follow in Sacramento, emphasizing team approach and dedication and planning to achieve the results we're trying to accomplish here in Sacramento. For the team, which one is going first?
Everyone hear me okay? So we're here today to share our approach and our story to diabetes care using a multidisciplinary team that's pharmacist-led. And so this is our agenda, but I just wanted to start with that we're just going to give you a really high-level overview and then save time for questions in the end specific to what may be of interest to you. And we're going to have a team perspective, PCP perspective, and a patient perspective to share with you, and then we'll wrap it up with some lessons learned along the way. So I wanted to take a second to do a high-level organizational overview, just so you have a feeling of who we are. We may be structured very similarly to you. MemorialCare is an integrated healthcare delivery system. The dark green across the top are the major divisions. In the middle, you'll see the physician division. And if you follow that down a little bit further, you'll see the MemorialCare Medical Foundation, and that also branches off into other divisions. But today, what we're most interested in is our provider group division, and specifically our IPA, which is Greater Newport Physicians. So we are located in Southern California, Orange County, to be specific, and the geography is quite large. It goes from Long Beach all the way down to Aliso Viejo. We have about 130 primary care physicians, and we contract with several community specialists. The organization has been in business for over 30 years. Its strength is managed care, but recently, over the past few years, we've been participating in some of the ACOs. And specifically of note is a direct-to-employer ACO, which is Coyne. In terms of the number of lives, I would say there's probably around 50,000 managed care lives and another 50,000 or so if you add in the PPO and Medicare fee-for-service lives. When I started at GNP 12 years ago, I was told that it was very unique as an IPA and that it acted more like a group than an IPA than other IPAs do. And I would say that that's true, and it's especially unique because as an IPA, it has clinical programs underneath it, and these clinical programs utilize a multidisciplinary team to help support the primary care physicians, and it's one of those programs that we're going to talk about today. So we've already been introduced. I guess I just wanted to say a bit, so I gave you the organizational overview. So the IPA is affiliated, it's not owned by the health system. However, myself and Dr. March are owned by the health system. So we support MemorialCare Medical Foundation. My training originally was an ambulatory care clinical pharmacist, and now I'm the VP of Clinical Pharmacy Services, so that ship has definitely sailed. And then Dr. March is actually a practicing ambulatory care clinical pharmacist, and she oversees what we call our GNP care clinics. And Dr. Coyne is a primary care physician with GNP, and he's going to give the PCP perspective of the program. His specialty is family medicine, and he is a member of our physician leadership committee as well as our quality committee, and he's serving as our champion today. So that's just a little bit about us. All right, so why did we choose diabetes? Oops. We made a decision 9 years ago to focus on the diabetic population, and the reasons are listed below. So I first want to say that primary care physicians do a fantastic job managing diabetic patients. And historically, when they run across that occasional, very challenging patient, they've been referring those patients to endocrinology, who also do a fantastic job managing diabetic patients. But there still is a subset of those patients who are very difficult to get to goal. They remain uncontrolled for many years at a time. And that's the population that we said we wanted to focus on. We wanted to build something differently so we could get those patients to goal. And the genesis of the program, the idea really began with a single PCP within the organization. She happened to be the president of the board of directors, but she was just so passionate about doing something to help the PCPs with this very hard and challenging population. So, it was her idea that first sparked the discussions. And, these are the patients that failed despite aggressive treatment and management by standard care. Another reason diabetes was important to us is because they're P4P measures, and there's quite a few of them. So, provider organizations pay attention to the P4P measures. And then, as a program, we would have an opportunity to have more than just one metric to gauge our success. So it's more than just the A1C. We're looking at blood pressure control, making sure patients are on the statin, making sure patients are getting their annual eye exam and foot exam and so on. So we could look at a lot of different things to measure our success. And we believe that actions taken today will have a dramatic impact clinically and financially to the organization. So how we started, it's funny that Nancy's here in the audience today. So I'm going to tell you how we started, but before I do, I'm going to say that you don't have to start that way. So we started with a grant, and it was actually a grant through Blue Shield. And, given what we know today, I can assure you that you don't need to start a program like this with a grant. All you need is an ROI calculation, and we'll share that with you as well. So we started with a grant, and we were actually affiliated with a different hospital system at the time, and so this was a joint program. Actually, we were in an ACO with Blue Shield, and so they furnished some of the staff, and they furnished the space, and we furnished some of the staff. So we shared the expenses of the program, and the multidisciplinary team was rather large, so we put the PCP at the top because the success of this program is that we work with each PCP individually, get to know what their comfort is and how they like patients managed. And the team that supports them was quite large. So we have an endocrinologist as a medical director. We have a PharmD, a nurse practitioner, we had a dietitian, and we had a social worker. I can tell you today, not all of those people are on the team. We started off very big, and then we become much more efficient and smart over time. If you are inclined to have a large team like this, we would advise that you create swim lanes so the clinicians aren't tripping over one another, and so everyone's clear what their role is and everybody's practicing at the top of their license. So the name of our program is the Active Diabetes Program, and it was named after the areas that were important to us, in other words, how we wanted the program to function. And what it's not is another educational class. And what it is going to be easier to show you over the next several slides than just to try to sum it up in this one slide. But in one sentence, we would say it's a program that integrates with a primary care physician to help treat challenging diabetic patients through coaching and medication management. So our target population is the poorly controlled diabetics, and today it's defined as an A1C greater than 8. In the early days, it was actually A1C greater than 9. So we lowered the criteria somewhere along the line. Our goal initially was to improve the A1C control in 30% of those very, very challenging patients. And we thought that was really going to be very hard for us to do. And the way we're going to do that is we were going to engage the patients through an individualized approach. So here's our